Good evening, everybody. Welcome to our very first virtual annual general meeting and annual members meeting, which our chair, David Walker, will officially open very shortly. I'm Lorcan O'Neill, Director of Communications. My team is supporting this event. This is a brave experiment. In the event of any technical glitches, we aim to carry on regardless, and we appreciate your patience and understanding with all that follows. There's an opportunity for you to put your questions to the panelists. Please use the Q&A function, which is illustrated here and available in the top right corner of your screens. Please enjoy the evening. I know that our chair, David, is keen to get things underway. And so, David, without further ado, it's over to you.
Good evening and welcome to the annual general meeting, the first virtual annual general meeting of the OxfordHealth NHS Foundation Trust. The agenda's up there, and basically this is the meeting where we present the trust's annual report and accounts. First, a bit of business. I'm taking the minutes of last year's meeting as read and record apologies from Tina Kenny, Paul Miller, Sula Wiltshire, Alan Johnson, Neil Ostler, Angela McPherson, Laurie Stratford, and from Tim Boylan and Lucy Weston. Our board colleague Arup Mazunda was doubtful. Lucy, who chairs our audit committee, was especially disappointed not to make the meeting, which unfortunately clashes with the AGM of a social housing provider that she chairs. A few brief remarks from me, if I may. What a year it's been. I was on one of our wards earlier this week and was again reminded of how staff have worked tirelessly, struggled in and out of PPE once they got it, and managed to minimise cases of COVID among our patients. So, to all our inpatient staff in mental health, as in the community hospitals, and to all those who visit people in their homes, to all our clinical people, to all those who make their work possible, running IT, logistics, pharmaceutical supplies, organising their pay, and beyond them, the brigade of volunteers who stepped forward during the spring emergency. Heartfelt thanks. And my expression of deep pride of chairing an organisation that responded so swiftly and seamlessly to the crisis and will do again if called upon. In the midst of all of that, we welcomed a new chief executive who's going to speak shortly. Our deep thanks to his predecessor, Stuart Bell, for his stewardship of the trust. Now, our annual report and accounts will give you details, but let me very briefly pick out some themes from the past 12 months. Talking positively about money, and our financial director will kick me for saying this, talking positively about money for healthcare is to invite hubris. But this year we have seen signs that the long promised re-equilibration of funds for mental health is beginning, locally, as well as in accordance with promises made in national plans. There are many miles to go, and securing justice for mental health and community services will go on depending on your advocacy and your willingness to make a noise that's audible in the corridors of power. Something else has started happening, which surely also must be welcome. We've begun to get serious about integrating healthcare services in our area, and we're working in unprecedented ways with our colleagues in the NHS in Stoke Mandeville and Wickham, Reading and Newbury, and again at the Royal John Radcliffe and Horton, as well as with colleagues in local government. All I can say now is watch this space. These past months, consciousness has shifted on racial equality. We've questions to address this evening on staffing, racial justice and running the trust, and, for me especially, the presence of people from ethnic minority backgrounds around the board table. Now, before I hand over to Dr. Nick Broughton, our new Chief Executive, a public health message. Forgive me for this, but winter is coming, so get your flu jab. Nick.
David, thank you very much for that, and good evening, everyone. It's great to be here. As David said, I joined the trust earlier this year, actually in June, so I'm about 3 months into the role. I'm really enjoying the privilege of leading Oxford Health. I'd like to just reiterate what David said about highlighting the way our organisation has met the challenge to date of the COVID-19 pandemic. All our lives have been transformed since March by the onset of COVID-19. And I have been truly humbled by seeing how staff across the organisation have risen to the challenge and continue to do so. It has been humbling and it has really demonstrated the best of the organisation, and also highlighted that we work as a team It's not just about our frontline clinicians, our doctors, nurses, psychologists, or AHPs. It's about how they are supported by our estates and facilities team, our colleagues in IM&T, our colleagues in the finance department who pay the bills. It's been a real team effort, and for that I'm very, very grateful. As you'll see from this infographic, which we put together for this evening, the last year has been busy, to say the least. The organisation has continued to see large numbers of patients, nearly in excess of 1.3 million patient contacts during the calendar year. And as you'll see, we have supported tens of thousands of patients across the catchment areas that we serve. And that is a matter of great pride to us all, and something that we realise is of huge benefit and importance to the public we serve. And I'd like to thank you all for tuning in tonight. The very fact that you are listening to me and listening to this AGM is a reflection of the interest you have in the organisation, and for that we are very, very grateful. The year is summarised in some detail in the annual report, but I would like to just highlight a number of key developments. Firstly, we were inspected again by the Care Quality Commission, who rated the trust as good overall. This obviously was encouraging, not least because the inspectors noted that many of the conditions were in place for the organisation to become outstanding. And that is very much our focus now going forward. We want to realise the undoubted potential of OxfordHealth and ensure that we do become a truly outstanding organisation, not just to receive care in, but also to work in. We want to be the best possible employer so we can retain and recruit the best staff we can. It was great also that during the year we saw that the feedback from those who use our services, our patients, our service users, was by and large very positive. Just over 93% of our patients said they would recommend the trust as a place to receive care. And that was really encouraging. But again, highlighted there's still more we can do to ensure that everyone has a truly outstanding experience of the services that we provide. During the year, we saw the development of a number of key initiatives across the organisation. For example, we launched and led 3 regional new care model provider collaboratives. This is a relatively new innovation to look at how we can deliver specialist mental health services at greater scale, and in particular ensure that patients are not treated out of area. So we're leading provider collaboratives for forensic mental health services across the Thames Valley, in addition to ones for inpatient child and adolescent services and eating disorder services, and to date they are going well. We also rolled out mental health support teams to provide care in schools in every county we serve, and have introduced specialist perinatal mental health services and mental health crisis support services in Oxfordshire and Buckinghamshire. Our COVID response also saw us set up new services, not least the 24/7 Oxfordshire and Buckinghamshire mental health helpline for children and adults, which was launched in April this year with the valuable support from our third sector partners. As always is the case, our workforce remains our greatest asset, but recruiting staff during the last year remained a challenge. In part, this was a reflection of the cost of living in some of the catchment areas that we cover, particularly Buckinghamshire and Oxfordshire. And we continue to highlight this to government to try and ensure that terms and conditions can be amended to reflect the cost of living locally and help us retain the staff we need. We also, though, are keen to ensure that colleagues who work in the organisation have good career pathways and are able to progress and realise their full potential. So we've done a lot over the year to develop better career pathways for our colleagues and support career development at every level. We've initiated a comprehensive package of apprenticeships, we've introduced nursing associates and provided other professional training to support colleagues as they progress their careers. David has also touched on the importance of the organisation becoming one that truly embraces diversity and equality and ensures that there are no glass ceilings for people, no matter what their ethnic background. And that is a real focus for us as we move forward. We're working very hard now to ensure that we are a truly inclusive place to work and that our leadership reflects the communities we serve and the people working across the organisation. We are committed to create new opportunities and to break down barriers that might exist for women and people from ethnic minorities and ensure that everyone can thrive whilst working in Oxford Health. We also are very aware of the importance of supporting the well-being of our staff, both their physical well-being and their mental health well-being. This has never been more important, and we are very aware of the impact that the COVID-19 pandemic continues to have on our workforce. So we've introduced a number of new initiatives during the year to support staff better, including a 24/7 independent employee assistance programme for both staff and indeed their families. Linked to all of this, of course, is ensuring that the organisation has a great culture, a culture which ensures that everyone is valued, everyone is truly engaged, and everyone is truly empowered. And that will be one of the priorities for the organisation as we move forward this year. And indeed, by the end of this year, you'll see the organisation launch its first organisational development strategy, which will help set the direction to ensure that we do have a fantastic culture. David has already touched on the importance of commissioning and ensuring that our mental health services in particular are adequately resourced. And we have worked closely with our commissioners to ensure that this is the case and to ensure that going forward that we are able to deliver the ambitions for mental health services as set out in the NHS long-term plan, which was published early in 2019. Examples of the work we do include working with the Housing First project and with the Luther Street Medical Centre in Oxford to develop services for the homeless. We've developed mental health support teams for schools across the counties we serve. We are piloting the National Ageing Well programme to give timely support to older people in their own homes and have improved services to people with learning disabilities and autism. But again, there is more we need to do, particularly to ensure that those patients with learning disabilities and autism are supported effectively and we can provide them with the care and support they need in the communities to ensure they do not need to come into hospital. We've made progress in helping support people in their homes and indeed to avoid unnecessary admission to hospital. Going forward, more needs to be done, and I'm very pleased to report that already we have a very comprehensive transformation programme up and running, reflecting the additional financial support that we've now secured from our commissioners. Oxford Health does not work in isolation, but is part of a system. We are very pleased that we are part of the Buckinghamshire, Oxfordshire and Berkshire West integrated care system, and we've seen that system develop and grow over the last year. We are very keen going forward that we play a key role in that system and are helping lead the development of truly integrated pathways of care that better support the people we serve. Whilst obviously it's easy to focus on COVID and some of the significant challenges we're facing as a National Health Service, it's important also that we don't forget one of the great challenges facing the world, and that being climate change. Protecting our environment remains an important priority for the organisation, and we are committed to reducing our carbon footprint. Indeed, the COVID pandemic has highlighted that we can do things very differently and work in a far more environmentally friendly manner than we have done previously. We have seen that the extensive rollout of video consultations, which has reduced the need for the staff and indeed patients to travel to appointments. And last year we held our first Green Alert conference with the help of OxfordHealth charity and launched the Green Spaces framework, setting out how patients and staff will continue to develop outdoor spaces and enjoy the therapeutic benefits that nature provides. You'll hear later on this evening about some of the work we are doing with the Department of Psychiatry in the University of Oxford. One of the strengths of the Trust, I believe, is its academic links. And we're very proud of the relationships we have, not just with the University of Oxford, but with a wide range of other academic partners, including the University of Bedfordshire, Oxford Brookes University, Buckinghamshire New University, and indeed the University of Reading. We work very closely with the University of Oxford in particular, though, training our doctors, psychologists, and carrying out research in psychiatry, psychology, and primary care. And the year saw that relationship strengthen. It saw a renewal of the Oxford Academic Health Science Partnership, in which we work with the two Oxford universities and Oxford University Hospital Trust. We continue to help support the application of research as part of the Oxford Academic Health Science Network. And we also host one of only 2 mental health NIHR biomedical research centres in conjunction with the University of Oxford. And this continues to generate high impact research, which we're very proud. And again, you'll hear more about this from Professor Geddes and his team later this evening. David has already highlighted that the year saw some significant changes in leadership of the Trust, not least Stuart Bell retiring after a very long and distinguished career in the NHS, a career that extends back 38 years, the last 8 of which were spent at the helm of this organisation. And I would like to put on record my thanks to Stuart for all he has done for the organisation and indeed the legacy he has left me. But our board also saw a number of new appointments. Marie Crofts joined the organisation as Chief Nurse in June, following Ross Alstead's retirement. In July last year, Dominic Hardestry left the organisation and his role as Chief Operating Officer to become Chief Executive of Avon and Wiltshire Partnership NHS Trust. And I'd like to thank both Dominic and Ros for all they did for the organisation. Debbie Richards joined the Trust in July as Managing Director of our Mental Health and Learning Disability Services. And then in February this year, the Trust made a new appointment, appointing its first Managing Director for Primary and Community Care Services, that being Dr. Ben Riley, a GP who has worked in Oxford for a number of years. Ben and Debbie are 2 great appointments. I've greatly enjoyed working with them during my 3 months in post to date, and I have no doubt that they have strengthened the leadership team of the Trust and will continue to do great things in their new roles. I also acknowledge the fact that our chairman, indeed my boss, only joined the organisation in April last year, following Martin Howell's retirement. Already David has made a significant impact, and we are greatly enjoying working with him and the leadership he is providing the Trust. I've touched already on the COVID response and the challenges this has posed. I think it's important that I just revisit this because it has a profound impact on our services. I think what is really important to stress, though, is that throughout the pandemic, we have continued to provide the vast majority of the services that the Trust is commissioned to provide. We've continued to deliver a wide range of core services to patients, particularly all our mental health services, although we have had to do these in different ways. And I'd like again to recognise the efforts made by my colleagues across the organisation for the flexibility they have demonstrated. A significant number of colleagues have been redeployed and moved from their core service to work in different services to help our response to COVID. And their flexibility is hugely appreciated and something that we are very, very grateful for. We also should not underestimate the challenges for colleagues across the organisation of having to work with PPE and during the early stages of the pandemic, cope with all the uncertainties around PPE and indeed the nature of the virus itself. Our community services in particular have played a vital role in supporting the wider system's response to COVID. We've worked increasingly closely with our acute colleagues and our colleagues in primary care to ensure that patients can be adequately supported in their own homes whenever possible, and to ensure that patients can be promptly discharged from the acute hospitals we serve, to ensure that those beds can be utilised for patients experiencing COVID. Things have improved significantly in recent times, but as you'll be aware from the Prime Minister's address to the nation earlier this week, the situation is again deteriorating. But I can assure you that the Trust has robust plans in place and we're already preparing for what looks like being a significant second wave of COVID infections. Our mental health services have changed significantly in response to COVID. One of the things that we have done is adopt digital consultations and use these extremely widely across all our services. We've to date carried out in excess of 70,000 digital consultations, and I think that is one of the largest numbers across any mental health provider trust in the country. And again, the way our workforce has adapted to this and embraced new technology has been incredibly heartening and is a tribute to their commitment to deliver the best possible services in often very difficult circumstances. To conclude, there are many people I would like to thank. As always, I would like to thank my colleagues across the Trust. We are blessed by having such a dedicated, passionate and committed workforce, and one which we can never take for granted. And please rest assured that going forward, ensuring your well-being will be an absolute priority for the leadership team of the Trust. But our workforce is supported by many key individuals, and in particular I'd like to put on record our thanks to our governors, the League of Friends of our community hospitals, all our volunteers, and of course the members of the Trust. Your support is hugely appreciated and greatly valued, and we will not take this for granted. So thank you for all you're doing, and thank you again for your support this evening. I do hope that you find this evening of interest and stimulating. I'm very sorry that we can't be having this conversation face to face, but hopefully next year things will be a good deal more like normal. Thank you again, and I look forward to receiving questions later in the evening. Now, one of the things we have to do this evening is receive the Trust's annual accounts, and to present these, my executive colleague, Mike McInerney, will now take over. Mike, over to you.
Thank you, Nick. I'd just draw people's attention to the fact that I'll be going through some key points in the accounts this evening, but the full set of accounts is available via a link on the website. And just to orientate you on these slides, where we have a column that says FY20, that means the year ended 31st of March 2020. Hence FY19 is the year ended 31st of March 2019, which is the prior year for comparison. So if I start at the bottom, that doesn't look very promising. Total comprehensive income for the year, a 3.8 million deficit against a 0.5 million deficit the prior year. So that looks considerably worse. However, if we move one line up to the revaluations, this is a revaluation of our properties, so it's not an operating issue. And you can see that there was an increase in valuation in the prior year FY19 and a decrease, almost the same decrease in the year we're talking about FY20. So if we remove those, the surplus position for the year was a 1.1 million surplus, and that is against the prior year of 5.7 million deficit. So significant improvement. And just to note, the plan for the year FY20 was a 2.8 million deficit. So it is an improvement over the plan as well. So if I take you just through to the income, you'll see a substantial increase in income across the years. So to the tune of 47 million. And there is also a substantial increase in expenses. And this is because we've invested significantly through the mental health investment standard, and also which is new funding to increase the spend on mental health. And also Oxfordshire CCG have increased their investment in mental health over and above that. There is also in there a significant amount of income from the provider collaboratives that Nick mentioned earlier. And so the net impact at the operating surplus level of this is a 6.1 million surplus against a 0.5 million deficit last year. And that is largely from the provider collaboratives and the increase in funding in mental health. For the financing cost, which is the next section below, you'll see that the finance cost has increased from 2 million from 1.6 million. And this is largely payment to the government effectively in interest for investment money that they have provided for to the trust. The gain loss on asset transfer disposals, this is a Hilltop Road, which was a small piece of land that we had adjacent to the Warnford site, and that's the profit from that. And that leaves us in that position of 1.1 million against 5.7 million. So if I move on to the next slide, which will talk about some of the complexities of money coming through. So this is to explain to you realistically the underlying performance of the trust. So in the box at the top, we have money coming into the trust, as other trusts do, which is provided in year, and this is Provider Sustainability Fund, the PSF, and the Financial Recovery Fund, the FRF. So it's all very complicated, but is important. This money we received in the year was 4.9 million. Now, if we take our surplus for the year, the 1.1 million from the previous slide, and we remove this 4.9 million and some small other accounting adjustments, then we come to a deficit before exceptional items of 2.9 million. And this represents the underlying performance of the trust. So despite it looking good on the first slide you saw, we still have some way to go to get to the break-even position that all trusts are expected to in these future years. So the next page will cover the statement of financial position. So this is effectively the balance sheet. You will see assets. These are our non-current assets, are fixed assets, mainly estate, 152 against 158. The reduction is largely due to the devaluation. The other thing I would highlight here, which is a significant figure, is trade and other receivables, 38 million against the prior year of 24 million. And this is largely due to the money due to us from NHS England with regard to the provider collaborative. And in addition, because it's very current, is we started to incur COVID costs towards the end of March, and so there is 1.2 million of COVID recharge claims within that figure as well. But the net impact on the previous financial position for COVID was neutral for this particular period. So the next slide, next is the key financial indicators. And I won't run through these in detail, but these are just for information. NHS Improvement assesses the performance of trusts based around these indicators. And the ones where I would highlight we are not quite where we would like to be are agency, where we are significantly above the ceiling target that has been set for us by NHS Improvement and NHS England. And this is something we are constantly looking to reduce the reliance on agency, but it is a constant battle for us. The other one I point out is the cost improvement programme is 6.5 million against the plan of 7.6 million. So some achievement, but we didn't quite manage to deliver on the plan itself. And then on to the final piece from me, which is really giving some indication of what we're looking at, well, the financial outlook. What does the future look like? Now, clearly COVID is having a significant impact right the way across the NHS. And currently, the normal financial position and situation and mechanics, if you like, of having a contract and working to that contract is on hold, and we are working to a regime through NHS England and working to recover costs spent on COVID, and also trying to accelerate now and implement for the second half of the year the mental health investment improvements. So they are not forgotten, they have been delayed, but we are looking to implement those within the 6 months of the second half of the year. The added piece here, which I think Nick referred to as well, is the increased focus on system-wide integration. So even a lot of the financial regime now is being integrated at the ICS level, the Bucks, Oxfordshire, West Berkshire, the Bob level. And this is, again, complicating matters, and we are having to work very closely together to ensure that we can ensure the best financial position for the for the whole of that ICS area, the system. And just for the next one, if we could move on to the next piece finally, is for OxfordHealth. Just to remind people, we have always been relatively efficient trust in what we do, and that continues to be the case. We did at the end of March, just before the COVID problems hit with a vengeance, we reached agreement with Oxfordshire CCG on increased investment into the mental health services in Oxfordshire. And we believe that if we can implement those effectively through to next year, then we should be in a balanced situation on those. We mentioned the underlying deficit, and again, with that additional investment, we should, as long as we can deliver on our cost improvement plans, we should be able to deliver on that break-even plan. I think the other thing, probably just to mention, because it is important in these times, is cash. The cash position is relatively strong, and if we can maintain that plan, we will be in a strong position at the end of this year as well. So I will finish there. I will now hand over to Lauren Griffiths from Grant Thornton, our external auditors.
Thanks, Mike. So my name is Lauren Griffiths and I manage the external audit for the Trust. And so I'm just going to talk through the work that we did in relation to the 1920 financial year. So the first slide sort of sets out the three key strains of the work that we do for OxfordHealth. So the first one is we give an opinion on the financial statements, and that opinion is on whether the accounts are true and fair, whether they're a fair reflection of the position and the performance of the Trust for the year. The second element is we issue a conclusion on it's called the value for money conclusion, which is slightly misleading because the work we do is looking at the arrangements that the Trust have in place in order to secure value for money. So it's not a conclusion on whether they have achieved it, it's a conclusion on the sort of underlying governance arrangements. And then the third element of the work that we normally do is we do some sample testing of some of the indicators that are included in the Trust's quality report. But as a result of COVID-19, the requirement to have that report audited was removed for this year, so that work did not take place. So if you move on to the next slide, I'll just talk in a bit more detail about the financial statements audit. So this is a brief summary of what we actually look at when we're doing our audit. So the overarching opinion is on whether the financial statements give a true and fair view of the Trust. All of our work is done bearing in mind the concept of materiality, which I will go on to explain in a minute. But effectively, we look for kind of any errors that would lead someone to read the accounts differently. We also check that the financial statements themselves have been prepared in line with guidance and requirements set out by the Department of Health. The third element of what we do is we consider what's called the going concern assumption, which I will again go into a bit more detail in a minute, but this is sort of looking forward 12 months from the date that we sign our opinion. Effectively, it's the sort of financial viability of the Trust in 12 months' time. And then we look at the annual report as a whole, and we look at the annual governance statement, and we check that those reports have all of the elements they're required to contain, and we check whether they're inconsistent with our knowledge of the Trust. So moving on to the next page, I just wanted to give a bit of an explanation of what we mean when we talk about materiality. So a misstatement or an error in the accounts would be considered to be material if it would change the way that you interpreted the accounts, and if it would change the decisions that you made based on the interpretation. So for OxfordHealth, we determined that materiality will be based as effectively on the benchmark of the operating costs of the Trust. And for the 1920 financial year, we set that threshold at £6 million. So in our view, an error would be material if it was greater than £6 million. We also consider whether there should be any other areas in the accounts where we look at them in a bit more detail. And we have set a separate lower materiality for the disclosures of senior officers' pay. So we would consider an error in that note to be material if it was more than £100,000. So if we move on to the next slide, this is the areas that we look at in the most detail in the audit. So we determine what we consider to be material, and then using that materiality threshold, we assess where the financial statements have the greatest risk of misstatement. So the first two on this slide are kind of presumed risks under the ISAs, which are the international standards for auditing. So there is a presumed risk that revenue is misstated, which can be rebutted, but in most NHS bodies we do not rebut that risk. And there is a presumed risk of management overriding internal controls, which we cannot rebut. That is a presumed risk in every audit. And the third risk on this slide is effectively there because it's a very big number, and it involves a lot of judgment, a lot of estimate, and the trust have to sort of bring in experts to value their properties. So it is seen as a riskier element of the financial statements. So as the slide sets out, we didn't find any issues in any of our work in those three areas. And we sort of set out at the bottom there. We also do a large amount of work on how the trust spends its money, but that is seen as less risky than the income that is in the financial statements. But again, we didn't find any issues there. So if we move to the next slide, just a bit on going concern. So going concern is looking forward 12 months from the date that the accounts and the audit opinion are signed. An entity is a going concern if in 12 months' time it will still be operating normally. So the trust do an assessment based on their financial plans, based on their savings plans, and based on sort of forecast cash flow levels for those 12 months. And we review all of that work that they've done, and we kind of challenge the key assumptions, and possibly do a bit of sort of sensitivity analysis to see, well, what would happen if income was lower than they expected? What would happen if they don't hit some of their savings targets? And for this year, we've concluded that the assumption that the trust will be a going concern is sound, and we have nothing to report in that on that. So on the next page, I do just set out that the opinion on the financial statements for the 1920 year was unmodified, so it was a clean audit opinion on both the financial statements and on that going concern assessment. So on the next slide, we'll talk a bit about the value for money conclusion. So this is a summary of our requirements, the requirements of the work we do. So we are looking at whether the trust has proper arrangements in place for securing economy, efficiency and effectiveness in its use of resources. So there are three mandated criteria that we look at, and those are mandated by the National Audit Office. And we effectively only report where we find problems in our audit opinion. So on the next slide, we identified one risk in terms of the value for money conclusion for OxfordHealth for the 1920 year, and that was around financial position and financial sustainability. And that was driven largely by the fact that the financial plan for the year was a challenging plan. There was a large level of planned savings within it, and there was £7.5 million of savings in the financial plan, and a lot of that was planned for the second half of the year. So the risk was that if any of those plans started to slip, that would lead to sort of non-delivery of the savings plans. So on the next slide, we held various meetings with management throughout the course of the year. And we've sort of reviewed monthly reporting, and we've reviewed sort of forward planning and how management are considering the impacts of COVID and how that was being fed into planning going forwards. And we've considered the fact that the trust obviously did make a surplus this year, and so did did deliver their financial plan. And then if we move on and on again, we issued an unqualified conclusion on the Trust's arrangements for the 1920 financial year. And it's worth mentioning here that the previous year we did qualify the Trust's value for money conclusion, so this is an improvement. That was all I was planning to say. So I believe we are now moving on to a Q&A session. So I believe I'm handing back to the chair for that.
Yes, you are, Lauren. Many thanks indeed. And thanks very much to you and your firm, and also to our internal auditors. I say this not just because I used to be a director of an audit organisation. It is a vital conversation to have between an organisation and those who are able, on a continuing basis, to examine with great care how well it's spending, in this case, public money. So thanks for that. Now, Lorcan O'Neill, our Director of Communications, is performing a vital function this evening, which is to filter and channel questions so that we can deal with as many as possible. Nick earlier used the phrase conversation. I hope this isn't just an occasion for a formal presentation. It will also be an occasion for an exchange of views. Lorcan, anything that you've picked up that we need urgently to address?
Thank you, Chair. Lots of questions coming in. The first one is from Governor Mike Hobbs, who asks, in light of a prediction featured in the Health Service Journal on the 23rd, does the board foresee a likelihood that OxfordHealth will merge with one or more acute NHS trusts?
Well, I'm going to hand that in just a minute to our Chief Executive, but all I can say, Mike, is that having had a conversation only yesterday with Jonathan Montgomery, the chair of OUH, he didn't then express huge ambition to take over us and our community services. But unless he's secretly got a plot, I don't think there's an imminent danger of takeover. However, Nick.
David, thank you. In my first chief executive role in Somerset, I jointly set in train work that led to the merger of the Community Mental Health Trust with the local acute trust. I think the situation there is rather different to the situation we find ourselves in Oxfordshire and Buckinghamshire. I think also linked to that is the question of scale. I think one has to think about how big an organisation can be for it to be effectively run. Certainly, I've had no conversations with my opposite numbers in either Buckinghamshire or Oxfordshire acute trusts regarding the possibility of a merger. What I would say though, Mike, is I think it's really important that we do all we can to break down the organisational barriers that exist between this organisation and our acute colleagues to ensure that we can deliver truly joined up and integrated care to our patients and service users. And I think that can happen without a merger. And I certainly think at the present time, if we started to have those talks, it would be a great distraction. We have enough on our plate as it stands without being distracted by talks of mergers and everything that follows from that.
Nick, there's a related question that came in a little later, which was, were there any plans to merge some departments such as HR or L&D with OUH to enable closer working and reduce costs while retaining an independent identity?
There are no plans at present, Lorcan, but obviously we always need to keep looking at how we can do things more efficiently and how we can use the limited public resource that we have as effectively as possible, but there are certainly no plans.
Thank you, Nick. Chair, the next question is another one from Mike Hobbs, our governor, who asks, in view of the grave reduction in charitable donations and fundraising over the past 6 COVID-dominated months, how can the Trust support and maintain effective collaboration with our valued third sector partners for the benefit of patients, carers and the wider community?
Again, Lorcan, thanks. So in a minute, I'll perhaps ask Nick to sort of pick this up, but it happens that Nick and I had a very interesting conversation only this week with the chair and chief executive of Oxfordshire Mind. Now, Mind, like other charities, both in mental health and in the wider voluntary sector, have suffered a major reduction in voluntary donations during the past few months. Oxfordshire Mind, thankfully, is in a reasonably stable, we were told, financial position, and that's good. However, going forward and looking not just at mental health, but at the array of voluntary organisations, it is the case that traditionally the voluntary sector did look to local government for sustaining funds, grants as well as contracts. And given the financial predicament local government in England finds itself in, that's a problematic area. I think all I'd say in general is that we are mindful that voluntary organisations do great things which shouldn't depend just upon the letting of contracts. There is an issue about their permanent income, and if in future there were a need for us to think about helping them sustain themselves, I hope as an NHS organisation, and that certainly reflects conversations we've had with other NHS bodies elsewhere, we would be able perhaps to prevent, God forbid, the collapse of an important charity. Nick.
Thank you, David. I think one of the great things about the Trust is the fact that it does partner with a relatively large range of third sector providers already, particularly in the field of mental health. And obviously that's one way of supporting these organisations and ensuring that they are sustainable by actually procuring services from them. And I'd like to think that going forward, the range of partner organisations will increase, and there are various conversations already in train regarding some innovative services that we may be able to develop during the course of this current financial year with third sector organisations across the patch. So that's certainly how I see things going. You know, we are becoming increasingly reliant on the third sector, and it's incredibly important we do all we can to support the third sector. The other thing to say is I think it's important that we engage with the third sector in its entirety. I'm rather hoping that our colleagues in Oxfordshire Mind will be able to help us in relation to this, because there are a number of relatively small charities that don't really get much of a voice and are often overlooked, and it's important that we are able to create forums for them so they can bring forward their views and provide, also highlight the great work they're doing. So I'd like to think that going forward this year we will see even more done to try and sort of support and create a really vibrant third sector community despite the obvious financial challenges.
Chair, with your permission, can we stay with Nick for a moment? There's a question about how we're addressing the staffing issue. We've got these expensive agencies, but they're responsive and agile. How do we compete with that? In Oxford and other areas, we have pressures on staffing. Is there anything being done to promote creative or innovative solutions for staffing rather than just more of the same?
Yes, there's a lot being done, Lorcan. I sort of touched on this briefly in my opening address, highlighting some of the innovative roles that have been created, sort of nurse apprenticeships, nurse associates, etc. So we can, develop colleagues at a relatively junior level and provide them with a sort of career pipeline going forward. We're very keen to create opportunities for colleagues across the organisation so they can progress and fulfil their potential. And linked to this is the work we're doing in relation to the organisation's culture. We really do want the organisation to be a great place to work, a place where people want to work, and a place where people can see themselves working for many, many years and fulfilling their potential. And I think one of the great strengths, again, of the Trust is its breadth of services and the geography it serves. So we already have lots of opportunities for people to move within the Trust to different teams, to great different experience, to increase their expertise and hopefully develop. But I suppose one thing to say in response to this as well is that we need to create roles that ensure that people can carry on in clinical roles and gain more senior positions in the organisation. And that's a real challenge, particularly for our colleagues in the allied health professions, where there's been a lack of senior roles. But again, Works in Train, and Marie Crofts, who is our Director of Nursing in AHPs, is leading that. And we've already created some more senior AHP roles. So there's more to do, but rest assured this is very much on our sort of to-do list and is absolutely key to the cultural change programme that we are taking forward this year.
Thank you, Nick. David, we've got a lot of questions coming in. I'm not sure we're going to get through everything we've been asked, but I know there's a subject that's very dear to you, and we've had a series of questions on BAME staff, which I'd like to perhaps pull some of them together into a few questions. One of them is underrepresentation in senior grades of BAME staff, with just 12 to 15 people in leadership and management positions. Sorry, it says, the question says, of around 12 to 15 people in leadership and management positions, none are BAME. I'm not sure that's entirely accurate, but this is that's with reference to one team. I'm sorry, the questioner didn't say which team. The question is that replicated across the trust? What is the trust doing to proactively recruit BAME staff into leadership positions?
Well, again, Nick can perhaps address it, but I'd like to say from my point of view, as sort of chair of the board, that we entirely recognise this issue, and the practical solution, the practical way forward has to be, when a vacancy occurs, to try and ensure that the pool of candidates is enriched by the full presence of people from BAME backgrounds, and I would have to say people with other of the so-called attributes of inequality, women, people with disabilities, service users, and really make a concerted effort to try and find candidates. At the moment, I am looking to replace a non-executive director role, and we are really trying hard to make sure that the field of candidates does include a fair selection of people from different backgrounds, so that we are able at least to try and attempt to diversify a board that I would be the first to admit doesn't look as diverse as it should, both to reflect the area we serve and to reflect the staff that we have. Nick?
Yes, thanks, David. And this is an incredibly important issue, and I'm very pleased that this question is being posed to us. Ensuring that our BME colleagues have a strong, powerful voice across the organisation is something that we are absolutely committed to putting in place. And I think there's been a significant move and change already during the course of this year in relation to this. We need to ensure that Oxford Health is a truly inclusive place to work, and is an organisation that truly values diversity, and that there are no glass ceilings, that there are opportunities available to everyone, no matter what their professional background, their ethnicity, their gender. And again, Lorcan, just to I'm sorry to repeat myself, but this is key to our cultural change programme. And to do that, and to ensure that we have colleagues from BME backgrounds in more senior leadership positions, we do need to actively encourage people and make people realise that these are opportunities that are available to them. And I think we will see that happening in very short order. And once we get to that point, a virtuous circle will be created, I have no doubt, because role modelling is incredibly important in this area. We need to demonstrate to people that there are people who they can follow, the people who can lead by example. And again, with David's leadership and my leadership and the absolute commitment to the wider board to this, I have no doubt this will happen. And what I would say as well, just to conclude, Lorcan, already in the short period of time I've been in post, a lot of board time's been spent discussing how we can move forward and address this issue, and we very much realise that it's a problem, that the organisation is behind the curve. We need to actually turn well-meaning words into action, and that is now happening.
Thank you. The sort of related questions, BAME staff are proportionately more at risk of death during the COVID crisis. What is the Trust doing to protect them? And what are we doing about the overrepresentation of BAME staff in disciplinary panels?
Nick, do you want to pick that one up?
Yes, so the key thing to ensuring that staff are safe at work, particularly in relation to COVID, Lorcan, is carrying out the risk assessments. This was something that we rolled out several weeks ago. I believe all our staff have now completed the risk assessment, and that's helped us ensure that those colleagues who are in direct clinical services are safe to be in those places, those services. And this is an ongoing process. It's a dynamic process, and it's being led and coordinated by Ben Riley, who's a GP by background. So that, in essence, is what we're doing to ensure that it's safe for our BME colleagues. And I suppose just to stress to people listening, if there are any concerns, and if we don't think it's safe for someone to be at work, we will ensure that they're not in that job, but we will find alternative work for them to do in the organisation. Ensuring our colleagues' safety is of paramount importance, as you'd expect it to be. In terms of the disciplinary thing, again, this is a real worry for us, and it's disappointing that this is the case. Again, it comes back to culture, and again, it's something that we are addressing. And Tim Boylan, who can't be here today, who's our Director of HR, is leading this work, supported by Mo Patel and Tamina and others. And we're working very closely with staff side, and I've been really impressed by the relationship that the Trust leadership team has with our staff side leads, and this is something which is regularly discussed in the staff side meetings. But we're not on top of this issue yet, and there's more to do. And I would hope that we will see significant changes again in very short order.
We are running out of time on the questions section, and we've had lots more questions than I think we can quite answer. However, I wonder if we could address green issues. There's a question about what are we doing to ensure that green initiatives are planned to benefit the environment, but also our staff and patients? Are we planning to do anything like installing electric charging points? Are we going to be using more food recycling and composting? So what are we doing about environmental issues?
First to observe, it is somewhat reassuring, Lorcan, that few of these questions are directly related to our financial position, and Mike might take some comfort from the fact that there does appear to be fair stability on that front in terms of the direction of questions. The trivial answer to your question is typical of the NHS. We now have a sustainability governance. We're meeting under my chairmanship on a regular basis with people from across the trust to try and pool ideas about what we can do. There's no question that COVID has been a benefit. We are able to, there's been a large reduction in what we call business mileage. People have needed to travel less. And I hope that means that the carbon footprint of Oxford Health in 2021 will be a good deal less than in previous years. Nick can maybe add some detail to this, but we have a programme of rolling out electric charging points. We are actively looking at trying to provide or incentivise staff to buy or lease electric vehicles. So there is an ongoing problem, lots of detail, light bulbs, the use of paper, use of printing, etc., etc. A lot is happening, but Nick observed this in his opening remarks. There's a huge amount more. You know, COVID aside, sustainability of us, sustainability of our country, of our planet, it has to be of paramount importance. Nick.
Thanks, David. And one of the reasons why I touched on this in my opening remarks is because it is a key priority for the organisation. Claire Daly, who is our Director of Estates and Services, is helping lead this work. David's already described some of the stuff that's in train, and I think in essence, you know, COVID has demonstrated to us that we can do things very, very differently and work in a way that has a far reduced carbon footprint. And we are absolutely committed to sort of harnessing the learning from COVID to now look at how we can work remotely, how colleagues can work more flexibly, how we can reduce the reliance on motor vehicles, how we can do more things via video consultation, reducing the need for people to travel for face-to-face meetings, etc. And you know, rolling out charging points again is key to this. I'm very keen on this, not least because it will mean I can charge my car and be able to travel between sites, which at times can be a bit of a challenge. And again, it's something that our colleagues at staff side regularly raise with us. And it's encouraging that we have so many colleagues across the organisation who care passionately about this. And I have no doubt that as a result, people will be holding me and the wider board very much to account in relation to what we're doing in order to reduce our carbon footprint.
A final question, and we weren't quite able to cover everything, but most things have been covered. It's really around digital, and we've had questions about people working from home, but I think the most pertinent one is around how digital is working with the people we care for. How is the Trust monitoring the lived experience of service users with the increased use of virtual and digital technology during the pandemic?
Nick, do you want to pick that one up?
Thank you. Well, we're regularly capturing feedback from our service users, but it is fair to say that we cannot assume that digital and video consultations work for everyone and necessarily equate to high quality care. And that's why we, in conjunction with the University of Oxford and a number of other partners, are in the process of carrying out a comprehensive piece of evaluation looking at video consultations and assessing whether they do actually provide the quality of care that we need them to do. This will take a bit of time, but again, it's something that we're looking at in some detail. But obviously, we harness feedback from service users and patients on a regular basis, and not least, we expect our colleagues who are liaising with service users and patients via video and digital means to be asking how it is for them. It's really important. We ask people about whether this is a way of engaging with services which works for them. And one size certainly doesn't fit all, and we're very cognizant of that. And very aware that for some people, it's really important that all their contact with the trust is face-to-face and not via video link.
Thank you, Nick. I think, David, that's as many questions as we can squeeze in without running hopelessly over time. So I'm going to pass back to you for the next section of the AGM.
Thanks very much, Lorcan. We thought that obviously the financial accounts are important and the annual report, but it would be good to use this occasion to try and exemplify three of the pillars on which Oxford Health sits. Mental health, and we're going to be hearing from Bill Tiplady and colleagues about talking therapies. Community services, we're going to hear from Tamina Ahmed and Ajmal and her colleagues on that. And also research and development. Nick's already referred to the richness of the trust relationship with particularly the University of Oxford, and we're going to hear shortly from Professor John Geddes and his colleagues about our research and development activities. There'll be a chance after each of the presentations in those spheres to pick up questions and get some answers from colleagues. But first of all, I'm going to hand over to Bill Tiplady and psychological therapies.
Good evening. I'm Dr. Bill Tiplady and I'm the Trust Associate Director of Psychological Therapies. I'm delighted to be introducing the mental health presentation this evening, and I'm more delighted still that it centres on the work of our talking therapy services. I'm going to be joined tonight by Joe Ryder and John Pym, who are our psychological therapies leads for Oxfordshire and Buckinghamshire respectively. We're going to talk to you this evening about the work of our talking therapy services and how this relates to the wider system. Firstly, I'm going to say something about the mental health impact of COVID-19 and about work we've been doing on meeting the psychosocial needs of Oxford Health staff. Joe's going to say something. We know that COVID has had a wide-ranging mental health impact. For people with existing mental health problems, it's been a particularly difficult time, although we know that some have shown great resilience. In the general population, we know there's been a real increase in experience of anxiety and low mood, and we know that this will translate into need for mental health services in the months and years to come. We know it's not been a uniform effect. Some groups in our society, including our BAME communities, have been disproportionately affected by COVID, and we know that the mental health impact has affected new groups. We know that women have been disproportionately affected by the disruption of social networks. We know that there's been a real impact on key workers and on people reliant on care coming in from outside the home. And we know that the future mental health impact of COVID will be a product of its effect on the social determinants of poor health. We know there'll be a wave of financial, employment and accommodation issues which will have a major impact in the year to come. And we know from Mind's work that the mental health impact of these issues will hit some more than others, with again our BAME communities and the younger age range likely to be particularly affected. As the Mental Health Foundation put it, we're all in the same storm, but not all in the same boat. We know we'll have to tailor our services to meet these different needs. Finally, I want to tell you about some of the work we've been doing on meeting the psychosocial needs of our staff and wider communities. This has happened through the Psychosocial Response Group, which is a multidisciplinary group which brings together a range of different trust functions with psychological leadership. We've been thinking about the demands of COVID in terms of the prepare phase, the active phase and the recovery phase. And we know that it's very likely, sadly, that we'll go back around through these phases again in a second wave. We've done a number of things. We've established a single point of access for all wellbeing support inquiries. We've given guidance for teams and staff on the importance of team huddles in the prepare phase, and we've developed a whole range of new wellbeing materials, videos and apps. We've designed thank you cards and sent those out to staff along with support packages. We've expanded our capacity to offer post-incident psychological support and expanded the definition of an incident to include the extended demands of the COVID situation. We've made sure that NHS staff have prioritised access to our talking therapy services. In the recovery phase, we've designed new materials to support people who've been redeployed or shielded come back into the workplace. And we've expanded our offer of team support, including offering team time sessions.
Moving on to consider the role of our improving access to psychological therapies service, more commonly known as IAPT, and our COVID response. For those that may not know a huge amount about IAPT, here is a brief overview. IAPT services provide NICE recommended evidence-based treatments for people with depression and/or anxiety disorders. Staff are also trained to provide interventions for people with comorbid long-term physical health conditions such as diabetes or persistent physical symptoms, as people with long-term physical health conditions are 3 times more likely to experience depression or anxiety. Services are delivered using a stepped care model which works according to the principle that people should be first offered the least intervention appropriate to their needs. For example, many people with mild to moderate depression or anxiety are likely to benefit from a course of low intensity treatment delivered by a psychological wellbeing practitioner. Individuals that do not fully recover at this level are stepped up to a course of high intensity treatment, such as cognitive behavioural therapy. As you would expect, all staff are appropriately trained and supervised to offer these interventions. And finally, one of the unique aspects and successes of IAPT is the use of routine clinical outcome measures. These have helped to demonstrate that IAPT services are both clinically and cost effective. In OxfordHealth, we have 2 IAPT services, Healthy Minds in Buckinghamshire and Talking Space Plus in Oxfordshire. Talking Space Plus is a formal partnership between OxfordHealth, Oxfordshire Mind and Principal Medical Limited. Both services offer a range of psychological interventions following a step care model, from computerised CBT to more traditional talking therapies such as cognitive behavioural therapy and other evidence-based interventions, as well as a wellbeing and employment support service. Moving on to consider our COVID response, both services have remained open and responsive to local need and demand. At the start of COVID, we became more public-facing, offering via our websites a range of resources, including short videos on wellbeing, social isolation, worry management and employment support. We also moved quickly to offer all our appointments via the telephone or through digital consultations. This included the delivery of all our groups and course programmes. Since the end of March, we have delivered approaching 67,000 appointments via telephone or digitally. The feedback from our patients has been very good, and our staff have also adapted well to this method of delivery. Due to COVID, we have also worked to enhance our clinical pathways for our most vulnerable groups, such as older adults, our Black, Asian and ethnic minority communities, and those with long-term physical health conditions. We also decided very early on to offer priority assessment and treatment to NHS and care home support staff to ensure they had timely access to support to help them return to work as quickly as possible. As we move to the restoration phase, evidence suggests that there may be a surge in people seeking help to improve their mental well-being. We are expecting more people to present with post-traumatic stress disorder, complex grief, bereavement, and some anxiety disorders such as health anxiety. We have provided further training to staff in all these areas so that we are prepared for the next phase. I will leave you with an example of one of our COVID videos on social isolation.
Loneliness and low mood can affect all of us from time to time, but with the ongoing situation with coronavirus, there is a whole new range of stresses that can make things like anxiety and low mood more common, and also more challenging to deal with. You may find that yourself or someone that you know or care about are struggling with being isolated at this time, and want to know how better to support them or yourself. We know that social isolation is an important way of preventing the spread of something like coronavirus, but it can affect our mental health. And although we have to be socially distanced, it doesn't mean we have to be emotionally apart. And this video is going to look at some ways in which we might manage ourselves and our mood during this difficult time.
It is really important during this time of social isolation that we do remain connected to the people around us, because that can really serve as a buffer to those symptoms of stress and low mood that we might be experiencing. You know, remaining in contact with those around us can really boost how we're feeling. And in considering the restrictions that we now have, is thinking about what alternative ways we can be considering. That can be for various different things. That might be through the simple means of Skyping with our friends and family, and with colleagues as well, thinking about planning exactly when you're going to Skype with each other to have your lunch together, or having a cup of tea or coffee. It might be through writing a letter, sending an email, sending cards to people, various different ways of correspondence, calling, texting, the usual means. The importance here is really thinking about the scheduling, because if we do schedule something, it means we're more likely to go ahead and do it. This may all feel really unnatural. However, the more and more that we do it, the more normal it will become. There are other things that we could be considering that will help things feel a bit more usual or normal. And this is all really to do with the routine that we have. You know, sticking to a similar routine that we would have had previously is really important. For example, you know, getting up, showering, eating at the usual times that you would have been doing. If you're working from home, considering to stick to your normal hours and designating a part of your home area to just your working life. If you have children and pets as well, keeping up with that similar routine. Also, if you didn't like your old routine, this is the perfect opportunity to try something different.
It can be helpful as well to plan other activities to do at this time, because we know that keeping busy and doing things makes us feel a bit more in control and can help improve our mood. It can be helpful to keep busy with things like cooking, or listening to music, watching films, perhaps playing games that you enjoy. Anything really that brings you pleasure or joy at this time can be useful to spend some time on. If you can, things like exercise can be really helpful. We know it improves our mood, and there's lots of stuff at the moment about different ways you can exercise from home. Whatever you can do safely can potentially help. If you can get outside, things like going for a walk and getting a bit of fresh air can really lift our mood and improve our well-being. I know that's been really helping myself at the moment to break up the working day from home, to get out and see a bit of nature. It's also worth thinking about things around the house that you'd normally be doing, and if you can stay on top of those, so things like cleaning and perhaps any jobs that you've been putting off. I know I've got some shelves that I've been meaning to put up for about 6 months, which I'm hoping now I might find a bit of time to actually get done and feel a bit more accomplished around that. If you find these things hard to motivate yourself to do, or find a struggle getting started, it can be really useful to make a list or a plan. Remember, planning makes it more likely that it will happen, and a bit of structure and routine can make things feel a little bit more straightforward. These things don't have to be big, they don't have to be time consuming. Any small changes that you can make can really help with your mood in the long run.
Social isolation is designed to prevent the spread of the virus, and we're all doing our bit for the society. We're so used to being able to come and go as we please and speak to and see whoever we want to, but we have to learn new ways in order to contain and manage this. Just remember, take one day at a time.
As improving access to psychological therapy services, we realised we needed to reach out to our wider system. I'm going to give you a few examples of this. First, we wanted to share some of the learning we had about working remotely. And with NHS England, we put on a webinar for IHFT services where our CBT therapists and psychological wellbeing practitioners could share something about how they'd adapted their practice and how they looked after themselves working remotely. Over 1,500 people attended from many countries. We also wanted to integrate our work with our physical health services. And in Oxfordshire, the IHFT service worked with the Seymour COVID follow-up clinic, and in Buckinghamshire, the Healthy Mind service worked with the respiratory team to provide integrated physical and psychological care. Both IHFT services have employment advisors who provide people with support who are struggling at work or to find work. The Employment Advisory Service in Buckinghamshire worked with our Community Mental Health Team Employment Services and Buckinghamshire Business First to reach over 13,000 businesses to provide information and advice about supporting employees struggling with mental health difficulties. Our psychological therapists also provided support to our care homes, including short tools on how to support staff and ways in which you could address the concerns of residents. Finally, we worked in partnerships to try to establish a coordinated response. For example, in Buckinghamshire, we set up a COVID mental health strategic response group and a voluntary sector group. A good example of our partnership working was the work that we did around bereavement services. We brought together all those who were helping people who'd been bereaved to coordinate their efforts, thinking about sharing training and producing communications for the public and professionals. Looking forward, we're anticipating a surge in mental health demand. We've got to respond to this in many ways. Psychologically, we want to build the capacity of the IHFT services, and we also want to better support health and social care staff. We want to work with our physical health colleagues to get a more integrated response to people with long-term health conditions and those people recovering from COVID. And we want to do further work with our colleagues in the business and voluntary sectors around how we can support people in employment and those experiencing difficulties with debt, housing and relationships.
So, Bill, thank you. It's the opportunity for people to ask you questions. We haven't got lots of questions that have come in for this section, which is probably just as well because we're running short on time. But there's quite a tricky one, which is what are psychological services planning to do to deal with the current waiting lists in CAMHS, especially for ASD and ADHD assessments, which are running at a backlog or a minimum of 2 years.
Thanks, Lorcan. So, I mean, a good and important question, I think. I think that's certainly an area of our provision that I'm aware people are waiting much longer than they should do. And certainly it's something where there's a lot of discussion going on. I don't know if the detail has its place here, but that's certainly something where we're looking at a range of different solutions to see if we can use resources creatively to try and reduce that wait. It's not an equal problem across the patch, I would say. But certainly it's an issue in some areas, so it's a good thing to have a question about.
Thank you, Bill. Another question, how are psychological services addressing the stigma and fear of being treated for mental health issues as a staff member in our own trusts, especially if you're a psychologist yourself?
Well, that's another really good question. I mean, we know in general that NHS staff tend to experience perhaps even a higher rate of mental health difficulties in the general population. Sometimes that's to do with the particular kind of stress and pressure of the work itself. And we know that NHS staff are often, slow to come forward and look for help. That's due to a whole range of issues. And some of that is the stigma that we ourselves might hold about seeking help. In fact, I've been at meetings today about a new national rollout of a kind of hub model for looking at a different route for NHS staff to access mental health support. It's one of the potentially useful things that comes out of the COVID situation, thinking about a new confidential route into services, so NHS staff hopefully will be encouraged to seek help more readily.
Thank you, Bill. Another question, and unfortunately we are very short of time for these specific presentation related questions, but it's it feels like we've only had a few weeks of breathing space with COVID, and now we're in the second wave. How can you support our staff to build resilience in this situation?
So again, I mean, that's something where I've had a number of meetings and discussions about that this week, and we're thinking very carefully about what we can do. I mean, I would completely agree. I think many of our staff are, you know, still reeling from the demands of recent months, and staff have, of course, worked incredibly hard, and we've encouraged people to take a break where they can. But we know that now this is a situation that's turning from an acute crisis into, you know, an ongoing factor of our daily lives, and there's a number of things that we're thinking about in terms of how we can, you know, how we can routinely look at staff well-being and monitor that in a more proactive way. There's a particular app that's being researched which helps staff to flag their well-being on a regular basis and directs them to support where that's indicated. But also we need to think again with our teams and our managers to make sure that they're aware of how they can help their teams to have breaks, to take time out where teams are becoming overwhelmed, and to make sure that well-being and stress are things that are regularly talked about and discussed in teams. I think it's a really important challenge, and we know that the months ahead are going to be a tough time.
Thank you, Bill. That's really helpful. I think we've run out of time for questions on that, and probably need to move on to the next presentation.
Thanks, Lorcan.
Thank you, Bill.
Good evening, can you hear me?
Yes, thanks to me.
I'm really sorry, I was looking for the red square, so I've managed to fail the test, so at least it was me. Yeah. Thank you very much. Apologies.
You're on.
So good evening, I'm Tamina Rajmal and I'm the Director of Primary and Community Care Services, and I'm here this evening just to tell you a little bit about the amazing services that we provide and have provided over the last year. I think it's been very well rehearsed this evening. We have all felt the impact of COVID-19, but I wanted to make the point that it's not just our staff at work, but also they have been experiencing those challenges at home as well. So it has been an all-encompassing experience for everybody that works at the Trust. We've always been really proud of our staff in community services. We deliver a third of the services across the organisation, but in recent months we've seen staff at their absolute best, and they have provided completely outstanding care. Every one of our staff has been impressive, not just the people delivering frontline care, but people in offices making sure that PPE has been organised and sent to our colleagues, people staffing phones and making sure that all of our services can run as well as they can do. So we have been enormously proud of our staff. I think, as we said earlier, and Nick mentioned, we have been able to maintain a majority of our core services for our vulnerable patients. So we have seen people at home, our district nurses and our community therapists, our hospital at home service. People have been able to visit our urgent care units. We've still been able to care for people in our inpatient beds. We've still offered safeguarding support for vulnerable children and families in the community. But we have had to do that in some different ways. So we've made very good use of digital consultations. We have a very good example of how we've supported our stroke patients when they've been discharged from our stroke unit to make sure that they're still able to rehabilitate at home. And we've got a lovely YouTube video for that if you want to have a look at it. We've done walking sessions with our young people. We've supported people by telephone. So we have worked very differently. We've not just focused on our own services, we've been really pivotal in working with our partners in Oxfordshire and Buckinghamshire. In Oxfordshire, we set up what we described as hot clinics for patients with COVID-19 where it wasn't safe for them to visit their surgeries. We set up community testing in the Churchill Hospital, and we supported testing for our staff. We did a lot of work to support our care homes, and you'll be aware that there was a very big focus on the impact that COVID has had on care homes, and we did a huge amount of work to make sure that the staff and residents there were supported and able to deliver care and keep people safe. And we recognised that it was important to care for people at home as often and as well as possible. So we did a lot of work to make sure that there was nobody in our acute or our community hospital beds who could be supported and cared for at home. We came to work and we kept going. And we keep going because we know that we're only halfway through this, and we have our winter coming and we have our second wave of COVID coming. So we recognise that we need to take a deep breath and look ahead. Could I have the next slide, please? In recent weeks, many of our services have returned to normal, but we do recognise we need to ready ourselves for the challenges of the next few months. My colleague Emma Lever was visiting staff in one of our community hospital wards, and she was talking to one of our healthcare assistants, and they had a really difficult time at the beginning of the year, and that healthcare assistant said, well, we're ready now. And I think that's absolutely fantastic. So learning from their experience, we learned a lot, we know what we're doing now, and it's pretty much sort of bring it on. So I think that's a fantastic statement about the staff that we have working in our services. But our staff are tired, and much as Bill's been saying, we do need to make sure that we continue to focus on their health and well-being, encouraging people to take leave, making sure they don't work too long hours, providing food in wards when it's difficult for them to get to shops, and just doing small caring things to make sure that staff realise that we are there and we notice the work that they're doing. But it isn't all about winter, and it isn't all about COVID. So we are working very hard to think about the services that we deliver now and into the future, really thinking about different ways in which we can do it, learning from what we've done this year. But we want to deliver evidence-based, high-quality care for the youngest to the oldest members of our community, and we look forward to talk to members of our community about how we might do that. But I think the best way to show what we can do and how well we do it is to provide you with an example. So I think it's fantastic to be able to introduce a member of our children's speech and language therapy services, Emma, who will be describing the work they do there. And then we'll hear from one of our young patients about the impact it's had on them. Thank you very much.
Hello, my name is Emma Topham and I'm a children's speech and language therapist at OxfordHealth NHS Foundation Trust. Very shortly, you'll be listening to a little girl called Lily, who is 10 years old. But before I hand you over to Lily, I thought it'd be really good for you to hear a little bit about her story, and how she's got to where she is currently. Lily was referred to the speech and language therapy service 3 years ago, and following her initial assessment, I diagnosed Lily with selective mutism. Selective mutism is an anxiety-based mental health disorder which usually commences in early childhood. Those with selective mutism often are able to speak relatively openly and confidently in some situations, but remain consistently silent in others. It's important to note that those with selective mutism, whether they are a child or an adult, they do want to speak, but find themselves physically unable to do so due to their anxiety. 3 years ago, Lily could speak when she was at home and with familiar people, but as soon as she stepped outside of the front door, she could not speak. So Lily did not speak when she was at school, when she was in the playground with her peers, or when she visited the park with her family. She also did not speak when she was at home and other relatives visited the home, such as her grandparents. Therapy has aimed to support Lily's understanding of selective mutism, but more importantly, what selective mutism means for her. Therapy has also aimed to support and shape Lily's communication. Initially, we focused on getting Lily to use gesture and pointing to enable her to express her most basic wants and needs, particularly in situations that she found incredibly anxiety-provoking. We then got her to practice making noises. Now, these were silly noises, like things like blowing a raspberry, whistling, or making a growling noise. And once she was doing this, we then practiced making speech sounds on their own. So a sound like a b or a k or a t. And once she was doing this, we then practiced getting her to sequence those sounds. So b, 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 or t, 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 or k, k, k. And then we got her to try and mouth words, so not using any speech. And once she was doing that, we then tried to see if she could use some of the sounds that we had been practicing to say some words out loud. And this sequencing of activities ultimately helped Lily to use audible speech. Once she was using spoken words and phrases, we then supported Lily to feel more confident speaking with a greater range of people. So we started using familiar people within her therapy program, and these were people that we knew she already felt comfortable speaking with, so people like her mum. And then once she was confident doing this, we then slowly integrated less familiar people into her therapy program, so people like her head teacher or a grandparent. And once she was doing this more consistently, we then did the same therapy activities but in different locations. For example, the canteen, her classroom, in the playground and in the park. And we did this to help Lily feel more confident speaking with different people and in different settings. In August of this year, Lily's school hosted a virtual assembly on the topic of what makes me special. The school encouraged children to send in audio recordings, video clips, drawings and photographs to help contribute to this assembly. I got in contact with Lily's family and asked them how we as a service can support Lily to contribute to this assembly. And what was amazing was, for the first time, Lily felt confident enough to verbalise and share her views on this topic. And this is what you're going to hear next, Lily's views. I hope when you listen to Lily, you'll realise how transformative the speech and language therapy service can be, and the trust as a whole, in shaping the lives of the children and the young people that we support, because we really can make such a difference to these children and young people's lives. I will now hand you over to Lily. Thank you.
What makes me special is my talking. People think I don't have a voice, and actually they're wrong, because Mum thinks I can be very loud. I have one now, and I use it all of the time. My voice helped me find friends over the summer holidays, and I love them so much. When I go to big school, I hope they'll still be my friends. When I got my voice, I also got to tell Grandpa that I don't like fish fingers, even though I get them every weekend. I'm a little bit worried that the thing I'm talking about here is boring because everyone has a voice. But I think my voice is even more special because I don't speak that often. I want everyone to hear it.
Tamina, Lorcan, actually, stunningly, your presentation was so comprehensive. We have had no questions come in on the Q&A. I don't know if there are any final remarks you'd like to make before we move to the next presentation.
No, I think I'd just like to say this is a really good example, but one of many examples of how our staff have worked with our patients and their families to keep them safe and help them improve and develop. And it is delightful to work in a directorate which looks after people right from the sort of cradle to the grave. So I'd like to say thank you very much to all of our staff, and thank you very much to Emma and Lily for showing us what we can do. Thanks very much.
Thanks, Tamina. And we're moving on now to the research presentation.
Hello, I'm John Geddes, Director of Research and Development at OxfordHealth. Research is a central part of the Trust's activities and generates many benefits for patients and staff in the area directly served by the Trust, but also across the wider NHS and internationally. Today's research is tomorrow's care. R&D in the Trust is constantly developing and growing. We've made major strides over the last decade in building research, particularly in mental health and dementia. We're now planning to work with the Trust and its patients to broaden research activity across the full geographical range of the Trust, including the community services. This afternoon, we'll present some of the work of R&D. First, Bill Wells, Head of R&D, will provide an overview of the current state of our infrastructure and activity. Dr. Kathy Henshaw, Head of Research Delivery in the Trust and NHR Associate Director of Nursing, will then describe the work she's led to improve the opportunities for patients to participate in research. Finally, Professor Andrea Cipriani, Associate Head of R&D, will present initiatives designed to help clinical staff participate in research. After the presentations, there'll be an opportunity for questions and answers, and I look forward to meeting you again then.
Oxford Health is one of the leading mental health and community trusts in terms of research activity. It is led by a senior management team which includes national and international experts and individuals who hold National Institute for Health Research roles. Some of the achievements of R&D are listed below, and they reflect our strategy to build research infrastructure via awards such as Clinical Research Facility, Biomedical Research Centre and Applied Research Collaborative. Developing this infrastructure allows high quality research to be undertaken and has the potential to attract further research and investment from funders. These developments were driven by the current R&D Director and Stuart Bell, CEO at the time, with support from the Trust Board. In addition to research infrastructure, we continue to build on our relationship with the University of Oxford and host a research management group. This group brings together stakeholders from across Oxford and acts as a forum to discuss the direction of research within the area. It is also important that the Trust builds wider relationships, and this slide provides a snapshot of some of our current partners. These relationships help us to share knowledge and provide more information for patients. They also allow us to be involved in the wider national discussions about research. Although at the end of the last financial year was impacted by COVID-19, we still achieved a lot. With over 2,500 participants recruited to mental health and dementia trials, the BRC recruited over 12,000 participants. It leveraged external income in excess of 12 million and funded almost 100 staff. And many of the BRC digital theme projects are now part of the Trust digital strategy. Another key ingredient in our research is the input from patients and public, and we currently have over 100 members in our various PPR groups. As a Trust, we've come a long way, but there are still challenges. Although we do have a lot of high quality people involved in research, they have limited capacity. COVID-19 has and probably will continue to impact on study delivery and income. We need to increase the inclusivity in our research, and the BRC and CRF renewal competitions, which start next year, will be very competitive. However, we do have some opportunities to meet this challenge. You'll hear next from Kathy about increasing participants for patients and Andrea about increasing research capacity for staff. We will also build on our collaborations, which will be key to the BRC and CRF renewals. So if we can meet these challenges, there will be an opportunity to not only renew, but also build on our current infrastructure awards, helping to build the reputation of the Trust and offer more opportunities for patients.
My name's Kathy Henshaw, and I'm going to talk to you about our opt-out initiative, which we developed to promote inclusivity and provide opportunities for patients to participate in research. So the problem at Oxford Health, as in many other NHS trusts, is that patients generally rely on clinicians to provide them with information about research opportunities. And this relies on clinicians being research active and or research engaged. And if they're not, of course, this can lead to inequitable standards of care in this regard. So in 2018, we carried out a pilot across the Mental Health Directorate of the Trust to really try and identify how many patients were being offered opportunities to participate in research. And sadly, what we found is that largely due to clinical pressures and a lack of clinician engagement, only around 11% of patients were being offered the possibility of taking part in research. We needed to do something about this, and to provide a bit of context, generally across England in NHS trusts, there are two main approaches for offering patients research opportunities. One is the clinician-led opt-in approach, which I've just talked about, and the second is an opt-out approach, whereby unless patients signal otherwise, they are offered information about potential research studies that might be relevant for them to participate in. Last year, as a result of this, we carried out a quality improvement project across the Trust to try and really ascertain which model was best suited to implementation at Oxford Health. This project was a mixed methods project and combined a variety of qualitative and quantitative approaches so that we could really gather a really high quality evidence base to inform our decision making. So our key findings showed that the vast majority of Oxford Health patients reported that they really wanted to hear about research opportunities. But despite this, they generally stated that they just didn't hear about these opportunities. Oxford Health staff in the majority agreed that all patients really should have the opportunity to hear about research participation. However, there was variance across the Trust regarding staff confidence in discussing research with patients. And the vast majority of participants, both patients and staff, were really very supportive of the opt-out approach. So we took these findings on board and we have decided to implement the opt-out approach trust-wide this year. So we got approval for opt-out from the executive management team in March 2020. We're just about to pilot, implement and evaluate the scheme across the Trust over a 12-month period. We've worked really hard with the comms team to generate a detailed comms plan so that we can promote the opt-out scheme trust-wide to patients and staff. And this, of course, achieves our ultimate aim of promoting inclusivity by providing patients opportunities to participate in research.
Good afternoon, I'm Andrea Cipriani, and I will present our initiatives to improve opportunities for staff to get involved in research and gain the skills required to deliver high-quality research in the NHS. Becoming a principal investigator is one of our recent initiatives. Just over 3 years, we managed to recruit 30 PIs, mainly consultant psychiatrists, but also psychologists and allied health professionals, across many directorates of the Trust: community, learning disabilities, older adults, CAMS, eating disorder, IAPT. And they have worked on 30 different studies, including a mix of clinical trials and observational studies. Our future plans include a mentorship scheme to develop new consultant PIs in a personalized way. They will shadow clinical trials, undertake clinical visits, they will gain experience of being sub-PI before they become a full PI. And people will have opportunity to apply both at the Wildlife Centre in Aylesbury and here in Oxford at the CRF. We want to have a 360-degree research opportunity with nominated person who will lead research for allied health professionals, and developing a similar mentorship scheme as we have for consultants, psychiatrists. We will work with district nursing teams to embed research in their Band 7 roles and support the development of nurse PIs. And finally, we have a forthcoming online R&D training package to support PI development remotely. As a Trust, we have to support our best people to become leaders in research at local, national and international level. The NIHR, the National Institute for Health Research, is funding people to become clinical academics. And the best example we have of success is what Kathy has done recently. Kathy has been appointed as a NIHR 7070 Senior Nurse Research Leader, and which means she's responsible for improving the capacity and capability of nurses to undertake research across the UK. Finally, an example of our response to the COVID-19 pandemic. Under the umbrella of the Oxford Health BRC, we produce an evidence-based guidance to help patients and clinicians manage mental health issues during the outbreak. Our English version is now translated in many foreign languages, including French, Turkish, Chinese. We managed to produce this important and impactful guidance in such a short amount of time only because we have a multidisciplinary team of people working together under the umbrella of the Oxford Health BRC. As a mental health Trust, our ambition is also to contribute actively to the international debate in the scientific literature. This is why we are publishing papers about what is innovative in mental health, for instance, psychiatry, but also what really matters to our patients. And we are, for instance, raising the importance of ethnic minorities, diversity, inequalities, all things that should inform policy in the UK, but also across the globe.
Thanks to our R&D team. Unfortunately, for technical reasons, and there had to be one, didn't there? John is unable to join us this evening, and we've been in frequent contact throughout. However, there are some questions, and I know some of the panel here may be able to help. And one of them is about attracting homegrown talent. I think Nick may want to come in on this one. To help develop more of our own staff and attract high quality academics and develop our own staff to work in research and in the things like the Biomedical Research Centre. Over to you, Nick.
Yes, clearly I can't answer with the expertise of John, but one of the things we want to do as an organisation is ensure that research opportunities are available to colleagues across the entire organisation, and also create the conditions whereby we can develop academics. We have lots of people who are at the start of their careers, whether they be medics or psychologists or nurses or AHPs, and many have an interest in research, and we want to help them to be able to develop that interest. And I think we have the conditions to do that, and I know that's very much part of John's thinking. And going forward this year, one of the things we want to do is to develop an R&D strategy for the organisation for the first time, which will encompass this. I've lost my my compere now. Lorcan.
I'm so sorry, it's classic live stuff. So Andrea Cipriani was phoning me to say, can he help with the questions? But we can't get him into the event for the technical reasons, which is really unfortunate. There was another question, which was around how can we make sure that patients are really fully informed about research? And I know we have plans to move towards a sort of opt-out system, but just given the pressures on clinical staff, can they get patients involved in research? I don't know if there's anything you'd like to say about that.
Yeah, that's very much part of the opt-out approach that was presented. What we're very aware of is that patients like being involved in research, and it improves their quality of experience of healthcare. So we are keen to ensure that patients across all our services, our dental services, our community physical health services, our mental health services, have an opportunity to be involved in research. And again, that's part of our strategic thinking going forward, and something I think you'll see develop during the course of this current year.
Thank you, Nick. And Andrea's texting me at the same time, so he really has been keen to try to take part. However, I think we're out of time for questions, and we should go over to our chair now for reflections and closing remarks.
Well, first of all, many thanks to all the contributors to this evening. It's been fascinating. And also thanks to those of you who have posed questions, and there may be a chance to follow up with a conversation around some of these themes later. Clearly, as Lorcan said, this is an experiment. If you have any observations about the conduct of an online meeting, platforms that we might alternatively use, and so on, we'd be glad to hear them. I have to say a very special thanks to Lorcan O'Neill, our Director of Communications, and to Victoria Taylor and to Emma Nolan and the wider comms team, because they've done a lot of work in making this possible, and I think it's been a fantastic success, although we will have to look forward to whether this form of communication is now permanent or whether we might possibly go back to face-to-face. Obviously, there are benefits from COVID. We've picked some of them up. It's a more sustainable form of communication to be able to hold meetings, not all meetings, but some meetings at a distance, saves mileage. I hope that when it comes to September 2021, we will take forward some of the themes and commitments that we've made this evening, for example, sustainability, I do hope that, and you will hold us to account, that Oxford Health is a more sustainable organisation in a year's time. Let me add to that, more seriously, a personal promise that when you look at the board of Oxford Health in a year's time, it will look different. It will look more diverse. It will look more representative of staff and community. Hold me to that. Earlier this evening, Nick used the term everyone truly engaged, everyone truly empowered. And that too has to be a commitment as we look at the year ahead. Not for its own sake, and not diversity for its own sake, but both for the sake of improving the outcomes of the treatments, the procedures, the services that we offer in mental health as in community. And the rich array of community was alluded to earlier by Tamina. So it's improving us internally in order to be a more effective deliverer of healthcare to the people of Oxfordshire, Buckinghamshire and the wider area that we cover. So on the screen, you'll see ways in which you can become a member of the Trust. You can take part, you can have some fun. HealthFest 2020 was a great event, even though it took place online. Thank you for joining us this evening. I would normally say safe journey home, but I will say stay safe at home. Thank you for being with us. See you again soon. Bye-bye.